Rajesh.
Well, at the outset, I would like to thank Rajesh sir for having me in this interesting session that is on tips. And this is the term that has been coined by Sir only. And I don't know whether it was discussed, but what tips means, tips in practice. So the basic idea is that we don't have to discuss too much of theory. We have to think about what are the practical tips that we take from this discussion, and we would like to have your inputs as well. So the first thing is that, when you are getting a case of infectious keratitis or a microbial keratitis, so any infection, whether it's in the chest or it's in it's anywhere in the body, the most important thing is that you identify the organism. And it's the same case in corneal ulcer as well. Identification of organism is the aim of management. How will you identify the organism? Because you have to hit the organism with the appropriate antibiotic. So how will you identify? One is by clinical diagnostic clues. There are certain clinical diagnostic clues which gives you idea that probably this is the organism. Then some rapid investigative modality that will help you to know that what can be the organism. And of course, third is definitive, that is culture sensitivity, but it takes a lot of time. So the first two are many times practically very useful. So clinical diagnostic clues depends on what are the symptoms and signs. So the routine symptoms are redness, pain, sensitivity to light, and discharge. And if you get to see a case wherein there is a corneal ulcer which is localized with distinct borders, no surrounding edema in the cornea, it can be staphylococcus. And staphylococcus is the most common organism that causes corneal ulcer. If you have something like undermining leading edges, serpiginous borders, you have hypopion, then you can think of pneumococcus species. If it's a fulminant greenish yellow discharge, rapidly proliferating ring ulcer, which is fast growing and progressing, then in that case, and plus if you have an ulcer infiltrate with surrounding edema, that is again suggestive towards Pseudomonas species with a history of use of contact lens. Then Moraxella species will mostly seen in diabetics, alcoholics, and you have these indolent ulcers which are oval-shaped, inferiorly located. Nocardia and mycobacteria can have cracked windshield appearance. Clostridium can have gas in the anterior chamber as well as in the stroma. In Neisseria, if there's infection by Neisseria, you get a wreath-like appearance. So all these things give you an idea what can be the organism, and then you can start your empirical treatment. Now, if there's a history of trauma with vegetative matter, then you can think in terms of fungal keratitis, particularly if somebody is having an indolent ulcer. The infiltrates have feathery margin. These are deep infiltrates, endothelial plaques, fixed hypopion. Then pigments on the ulcer, something like this, which can be seen in curvularia keratitis. So then a cotton wool kind of appearance, which is seen in candida keratitis. Then, so these things give you an idea that what can be the organism. Again, if somebody is a contact lens user and develops a keratitis, severe pain in the eye, then that can suggest towards acanthamoeba. Particularly if you have a ring infiltrate, something like this. This is a ring infiltrate, ring-shaped infiltrate. In such a case, and that person is giving a history of contact lens use, or sleeping while wearing contact lens, or swimming while using contact lens, with this ring ulcer, you can suspect two things. One is acanthamoeba, one is Pseudomonas. If it is fast growing, if it is rapidly progressing with surrounding edema, then it is Pseudomonas. And if it is a slow progressing, then it is acanthamoeba. So these are the two important features, two important organisms that can be seen with these ring infiltrates. And sometimes you can get scleritis in acanthamoeba keratitis, which is very commonly seen. Total epithelial defect, anterior chamber reaction, Earlier, we used to feel that it is viral, but over the last decade or so, people have come to know that it can be because of acanthamoeba. And if there is surrounding scleritis, scleral nodule causing atrophy of sclera, then it can be acanthamoeba. And viral keratitis can be considered if you have a dendritic pattern, something like this. You don't have to do any scraping, you don't have to do any investigation. Dendritic keratitis, this is a herpetic keratitis. Just give anti-viral treatment, it will take care of it. If it can be necrotizing keratitis, there can be, badly vascularized and sloughed up kind of appearance, or you can have an edema. Suddenly a patient develops coin-shaped edema or partial, Descemet's folds, partial corneal edema, and you check the sensation. Sensation is dull. The first thing that should come to your mind is herpetic keratitis. And if you have a subepithelial nummular infiltrates along with conjunctivitis, that can be adenoviral keratitis. So the basic idea is that large number of cases can be treated based on the clinical clues that you get from the appearance of the ulcer based on the history of the patient. Then you start empirical treatment, and studies have shown that in 75% of cases, if the diagnostic clues are suggestive, then the empirical treatment is effective and you don't have to change the antibiotics. And if the response is there and the culture sensitivity is showing something else, then also you don't have to change the antibiotic because the response is the key. So depending upon the response, if response is there, whatever be your investigative report, you continue with the same antibiotics, antifungals, etc. I'll just talk a little bit about special situations like post-LASIK keratitis. Why we should know that these can be the organisms? Because if somebody comes with a post-LASIK keratitis, the first thing that you should think about the organism can be atypical mycobacterium, staphylococcus, pseudomonas, polymicrobial. Now, staphylococcus and pseudomonas can be seen in the earlier phase. Suppose a patient has LASIK, had undergone LASIK, and develops a keratitis. 4 days later, you won't think of atypical mycobacterium. If it comes 10 days later, you will think of atypical mycobacterium. But if it comes 3 to 4 days later, you will think of staphylococcus. If there is surrounding edema along with infiltrate is there, you have measured the size, but surrounding edema is there, immediately start suspecting pseudomonas. So these are some of the diagnostic clues that helps you, because many times by the time you get the investigative report, the ulcer has progressed a lot. Again, post-intact keratitis, this is mostly seen, whatever reports are there, staphylococcus has been commonly seen. Infection after CXL has been seen. Infection after corneal graft has been seen by gram-positive cocci. Post-DSEC or post-anterior lamellar keratitis, if it is early, in nearly more than 90% of cases, the source is the donor tissue. Check the culture of the donor tissue, you will get the organism, and then you treat accordingly. And of course, in immunocompromised individuals, you can have polymicrobial keratitis and bullous keratopathy. Again, the local immunity is reduced, so then in that case, the flora and fauna in the ocular surface does that. Contact lens induced keratitis, very commonly seen, as I mentioned earlier. If you have a person who uses contact lens, has slept for 3 hours, got up, and then starts telling that there is redness in the eye, you examine the patient has infiltrates. Later on, next day, a couple of days, he shows ring infiltrate. If it's progressing fast, it is pseudomonas. If it's progressing slowly, it is acanthamoeba. So the idea is, the tip here is that the cause of infection also gives clues about the microorganism. And once again, going back to the main aim of management is to find out the microorganism. So the approach of management will be a very good history, good examination and investigations. You have gram stain, KOH, you have bacterial cultures, you have PCRs, you have, for fungus, you have KOH wet mount, subrods, dextrose agar, everything is there. PCR, rapid PCR, confo scan, everything is there. But the key is that if there is a corneal ulcer, if there is ulceration, if you just have to do one investigation, do KOH. rule out fungus. If it is not there, it is bacterial. Because a viral keratitis will give typically, initially, it will give a typical appearance of dendritic keratitis or a geographic pattern, etc. So that you know. PCR is quite effective. Acanthamoeba, as I said, that you can do staining with calcofluor white and cultures. I will not go into all these. Conform scan is a useful tool to detect the cysts and the trophozoids in the cornea. So in vivo, you can detect cysts, double-walled cysts in the cornea. You can see here, these are double-walled cysts. And you can also see in the basal epithelium, the trophozoids. So the point here is that if there is an ulcer or a dense infiltrate or a deep infiltrate, do KOH wet mount. If it is negative, think about bacterial keratitis. And then based on the appearance, which organism is there, you have to think about. Do a scraping. Now, regarding scraping, I would like to say that most of the times, many times, it is negative because of wrongly done scraping. Why? Because there is a tendency to just scrape the surface of the ulcer. You should first debride that. There's a lot of slough tissue on the surface. If you will take that, culture will be invariably negative. And if you have to scrape one part, scrape the margin, not the base. Because even after a little bit of debridement, you can still have some slough tissue in the base. But margin will definitely have the organism. So scrape the margin, that is very important. If you can do the base, that is also fine. As far as drug therapy is concerned, mostly for bacterial keratitis, we give combination therapy of cephalosporin and aminoglycoside. If the ulcer size is less than 2 millimeters, then you can go for a monotherapy of fluoroquinolone. If it is more than 2 millimeters, go for a combination therapy. Atypical organism, if you get, then accordingly you modify your antibiotic. Like atypical mycobacterium, you can give azithromycin, clarithromycin, amikacin. If you have any doubt, then amikacin is one drug which is very useful. It not only helps in atypical mycobacterium, it helps in nocardia, it helps in actinomyces, it helps in pseudomonas. So one thing you should remember, that if it's not a very clear-cut staphylococcus ulcer and you have doubt, instead of using a tobramycin, use amikacin. That will take care. Particularly if you have history of LASIK, etc., then it is very useful. One important point, if there is a post-LASIK keratitis, one important point is that you should do the flap amputation. That is very, very important, because unless you do flap amputation, it is not going to help. The ulcer is not going to heal. And if you have a post-LK or post-DSEC keratitis, remove the lenticule. And then you will not only get the organism, you will also get all these, you will manage to control the infection. Fungal keratitis, we have the topical antifungals. One thing I would like to emphasize here is that in fungal keratitis, debridement is very essential. Because we know if we get fungal, on KH wet mount, you get fungal hyphae. You will start the treatment, but it will not heal because of two reasons. One, because the fungal infiltrates are quite dense. And the drugs, antifungal drugs, do not penetrate that well. So debridement, frequent debridement is must. Not only just during scraping, but frequent debridement. And if it is inside, if it is deep infiltrate, you have to do a wash as well as give intracameral antifungals. So as you can see here, deep infiltrate, you just remove the hypopion and then wash it, give intracameral antifungals, and then you surround this part. If the infiltrate is deep, surround this part with intrastomal antifungals, and I'll just move fast, and that is it. In acanthamoeba, bigonide is the treatment of choice, PHMB or chlorhexidine, and if you have scleritis, you give systemic steroid. Mycophenolate is useful in scleritis. You give it in increasing dose. You don't just give it 1.5 gram BD immediately. You start with 500 gram BD, 500 milligram BD, then 1 gram BD, and then 1.5 gram BD. So that is the way it is given. If it's a hepatic keratitis, acyclovir is the treatment of choice in such a case. If a disciform keratitis, you have to give systemic acyclovir as well as topical steroid, hepatic endotheliitis, etc. AIOCT is a good tool to manage, to monitor these patients. As you can see here, that where there is a hepatic endotheliitis, this much is the thickness. You started the treatment. The thickness reduced, but you see the posterior translucency has not decreased that much. It is still there. This means the activity is still there. You have to keep giving steroid. And this is the end point. The reflection of every part of stroma is similar, and it is clear. So that is a good tool to handle. And I'll just move on. In adenoviral keratoconjunctivitis, just a word about it. If there are subepithelial nummular infiltrates in the center of the cornea, then you should give steroid if the visual acuity is reduced, because it will not go off without steroid. If it's in the periphery, there's no need to give steroid. But if it's in the center, causing reduction in visual acuity, give topical steroid. Along with that, give topical cyclosporin. You can taper off this steroid because there's a risk of recurrence. You can carry on with topical cyclosporin. And the last thing is microsporidia keratitis. We used to feel that it's more often seen in coastal region, but now we are getting a lot of such cases in Delhi and North, in other parts as well. Many treatment modalities have been tried, like fluoroquinolones, voriconazole, etc. The best thing is when it gives you a stuck-on appearance on the cornea, like something is stuck, just debride that and put the patient on a little bit of fluoroquinolone, and that will be useful. And if medical therapy fails, you have to do surgical management. Small perforation like this or an impending perforation, you can put glue. A little larger perforation in the periphery, you can put patch graft. I will skip the video for paucity of time. And a larger perforation and a central perforation, you do a tectonic graft like this. So the tips to manage corneal ulcer is rapidity. That is the most important thing. It's an urgency. It's an ophthalmic ocular emergency. We have to be very fast. Identification of organism is the key, because that is what we have to treat. We have to kill the organism, kill the bug. We can get clues from clinical diagnostic clues or by investigations. Proper scraping again is very important. Don't keep the slough tissue for evaluation. Remove that first, debride it, and then do it. And daily documentation is very important, because many times subjectivity does not help in managing these cases. Little bit of improvement can be seen only if you document daily. So that is very important. Thank you very much for your patient listening, and any input from you will be highly appreciated.
The claps say it all. Believe me, never before I have heard such a lucid talk on infective keratitis. And hats off to you. The confidence with which you spoke shows that so much knowledge you have. And
Thank you,
I think the time you can take more if you want. I can sacrifice my talk, but believe me, this was one of the most illuminating talk.
Thank you, sir.
And that was the whole purpose of session. You have revised Smolin partly for us, or those small tips, even a retina guy can understand.
Thank you, sir.
Yes, any comment?
Yeah.
I appreciate all the pictures you have presented, but generally what we come across are the patients who present late, ill-managed, and you can't differentiate from any kind of morphology is there. Only thing I have been able to differentiate sometimes is early viral ulcers, where dendritic patterns are seen. Rest, they keep on deteriorating. Finally, you keep on treating with fortified amikacin and all, cefazolin, and even give all the types of therapy like fluconazole also, then retamycin also, but they keep on deteriorating, and finally endophthalmitis, clear up the vitreous, and then also the cornea is melting and intrastromal amphotericin B, and still the patient does not get relief. So you have any comments to make about
Yeah.
the frequent presentations in our centers?
See, I mean, these things can happen, but I would say that we should not believe in cocktail therapy. We should have one direction. And if the patient has come to you very late and you're not very clear about the, you're not getting a proper diagnostic clue from the picture, then you have to do scraping. And as I said, there are two things that can be done. One is gram staining that will give you immediate result, and the other thing is KOH. And just listen to me first. And KOH is very important tool because it's not correct to keep giving everything, because what happens that sometimes if you give too much of antibiotics in cases of fungal keratitis, it will not respond.
You see, I have seen, Rajesh, a patient carrying a big chitta of
Yeah.
this thing, all the available antibiotics, antifungal, antiviral, all being given. So that cocktail, I don't think so
Yeah.
in clinical medicine is, you see, what happens ultimately, believe me, is that patient is putting more of lubricant drops than, antimicrobial.
Absolutely, and it dilutes everything. It dilutes everything. So
it
we
hurts,
want...
it hurts when, you are talking, भाई आप क्या-क्या दवाई डाल रहे हो? डॉक्टर साहब मैं फ्लोजेल डाल रहा हूँ, मैं ये डाल रहा हूँ. अरे दवाई क्या डाल रहे हो? So that is the problem of giving, one chitta of, I am talking of big people who 14, 15 medications written down there. So.
Stains also come negative because already so much treatment has been given.
Yeah,
KOH negative, culture negative.
So
proper
that's
knowledge level.
what Rajesh gave a tip where to take the scraping from.
Yeah.